Years of experience as a family nurse practitioner. She holds a master's degree in nursing science. She is a certified diabetes education and care specialist since 2003. This certification is from the National Certification Board of Diabetes Educators. She's completed months of advanced courses in diabetes management to qualify and successfully challenge the examination for board certified advanced diabetes manager from the American Association of Diabetes Educators in June of 2018. She's a member in good standing with AADE and the American Diabetes Association. And Kate, welcome. We're happy to have you here. And sorry we couldn't figure out the PowerPoint.
Yeah, I'm sorry too. And I apologize to everyone for the delay and the confusion. I do have 45 slides that you won't be able to see. And so maybe I can send it to you or somehow get the slides to you, but some of them will be helpful, but most of them we can just do together. So thank you, Jane, for that nice introduction. So I am Kathleen Vogelsang. I am a nurse practitioner. I've been a diabetes educator since 2005. Thank you for allowing me to talk about diabetes. So my objectives for this talk is to let you know that November has been Diabetes Awareness Month. And so I wanted to, bring that awareness to you because diabetes of all types, and we'll talk about the different types, but diabetes and pre-diabetes is a huge problem in the world, but especially in the United States. So the other objective is to bring you a meaningful talk. So I really want this to be a talk that's of value to you. I enjoy talking in front of groups, but that's not my main objective today. So I want to hear from you and make this meaningful. Adding to that, I would really actually enjoy maybe quarterly there's one disclaimer before I talk into what I would enjoy doing is that you will not know everything you need to know about diabetes and pre-diabetes in this 1 hour talk. There's a lot of information, especially for diabetes type 1 and 2 on technology, CGM and insulin pumps, as well as all the different types of medications. So I'm going to review all of that, but it would be nice. I would enjoy, in fact, doing quarterly update for if there's enough interest, on diabetes and diabetes education. So I have had a diabetes support group for 6 years at Mad River Hospital as part of my primary care work and my diabetes, love of diabetes education and sharing information. That support group was monthly for 6 years. And then COVID came. And so in March, we had to disband the face-to-face. And I actually retired for a while from work and patient care. But I would like to get that going again. And so that's my plan for the future of virtual support group. So other objectives today will be to review the different diagnostic categories for diabetes, to discuss how it's diagnosed and various treatment options and how to manage diabetes and pre-diabetes. So I also want to give a quick review on the history of insulin because it's interesting. And to finally discuss diabetes prevention. So I did have a slide with a copy of my certification to show you that I'm real here. So, but what is a CDECS? That's a lot of letters there. So it's an abbreviation for a Certified Diabetes Care and Education Specialist. CDCES, formerly known as a CDE or a Certified Diabetes Educator, is a healthcare professional who has chosen to specialize in diabetes. To be a CDCES, a professional needs to take clinical courses and has to have 1,000 hours of experience working with another diabetes educator, helping people manage diabetes in order just to qualify to sit for the national certification exam. So it's kind of a big deal. That exam was really hard. In 2019, the American Association of Diabetes Educators made the decision to change the title. So it's a little awkward, but perhaps it's more real because really someone like myself, who's a nurse practitioner and pharmacist, and MDs, actually do more than just education. They help people manage their disease. So perhaps that's okay. My next slide was actually my favorite poster that I use in diabetes education. I'm sorry you can't see it, but it shows the digestive system. It's a picture of the liver, the stomach, the intestines, shows you in clear image where your pancreas is. So the pancreas is a super valuable organ. Without its production of insulin, you can't live very long. And so it's right in the middle on the more central, but to the left near the stomach. So every once in a while, hug yourself across your torso to give your pancreas some kudos and some love. All right. It all works together, and we'll talk about that more later. So we'll start right with the beginning. And this may be redundant for many people, but it's important for me to say it anyway. So what is diabetes? So diabetes is a chronic health condition that affects how the body turns food into fuel. So glucose is the fuel source for our cells. The carbohydrate foods that we eat are broken down into glucose and other micronutrients. But glucose needs insulin as a key hormone that allows that glucose from the bloodstream, from our blood vessels, to move into the cells where it's utilized for our energy source. So diabetes is a disruption of the body's delicate homeostatic dance of glucose management. It's complex and it's really beautiful when it's working right. The result of the end result of someone who has diabetes is an elevated blood sugar. And over time, high glucose levels will lead to organ health problems. So chronic elevated blood glucose is very irritating to the endothelial lining in the blood vessels throughout our body, the brain, the nerves, the kidney, the skin, and the eyes. So I'm talking about chronic elevation of glucose. And lots of studies, the DCCT trial is 30 years old. That's relating more to type 1 diabetes. But there's so many trials that documented that good management of diabetes can help really prevent the side effects that we all know about. And we can talk about that more in the Q&A if you wanted to. So the CDC 2020 statistics are my next slide. This is the National Diabetes Statistics Report that was documented through health data collected up to 2018. So this is really current. So currently, 34.2 million Americans are diagnosed with diabetes. So that's 1 in 10. So that's why it's important, right? We need to know about diabetes. We need to be screened for it. So 95 to 99% of those total cases are type 2 diabetes. And the rest, 1 to 5%, is type 1 and other categories, which I'll review in a minute. So the cases are higher among non-Hispanic Blacks, people of Hispanic origin, as well as First Nations people, including Native Islanders and Native Alaskan people. And we'll talk about that too when we get to food as medicine, and what's going on with our food system. So unfortunately, according to the CDC, 15% of people with type 2 diabetes, and there's probably some with other types too, like type 1, are still smokers. So we know that smoking irritates the blood vessels. And we also know and documented through many studies like this DCCT trial that the chronic glucose elevates irritates our blood vessels, causing heart disease is the main concern there. So people need to have help to throw the cigarettes away. But 89%, this is according to the CDC, this is not making, I'm not making these up. As a 89% of people with type 2 diabetes are overweight, and 38% are physically inactive. So pre-diabetes really is a mind blower. 88 million Americans have pre-diabetes. So that's 1 in 3 Americans have pre-diabetes. And most of those people don't realize that they have pre-diabetes. So you need to be screened, and we'll talk about that in a minute. This is another reason why knowing about diabetes is important, because 1 out of every 7 of our US healthcare dollars are spent on caring for people with diabetes. I was recently listening to Dr. Radio, so I thought I'd put a plug in for Fred Feit, who's an interventional cardiologist retired from NYU. He reports that 50% of the patients he saw in his cardiac cath lab doing procedures, 50% of those individuals had diabetes as a primary diagnosis. And again, that's because it's very irritating to the endothelial lining of our blood vessels. So my next slide is one from the American Diabetes Association, and they state that diabetes is an epidemic in the United States, that according to the CDC control and prevention, and this is a 3-year-old slide that I have, so this is how much it's increased. They're stating 30 million Americans have diabetes and face its devastating consequences. So now it's 34.2 according to 2018 statistics. So diagnosis of diabetes costs an estimate of $39.5 billion in California each year. The serious complications include heart disease, stroke, amputation, end-stage kidney disease, blindness, and death. According to the ADA, or the American Diabetes Association, each year in the state of California, 263 people are diagnosed with diabetes. That's pretty shocking. Classifications of diabetes. So type 1 diabetes is an autoimmune condition that results in the destruction of the pancreatic beta cells. So a person diagnosed with type 1 diabetes is not able to make endogenous insulin. They're not, so their pancreas is not making any of their own insulin. Daily injections are needed. For most people, it's multiple injections a day are needed to live. So type 2 diabetes is a slower onset. There is a reduction in the sensitivity in insulin and a gradual decrease in the production of insulin. So let me say that again. It's the reduction in the sensitivity to insulin and a gradual decrease in the production of insulin that results in elevation of blood glucose. So another classification of diabetes is gestational diabetes, which occurs to a woman during pregnancy. It's usually screened these days in the 2nd to 3rd trimester. And the difference between type 2 and gestational diabetes is that after the baby is born, the blood sugar normalizes. And so, so diabetes goes away, if you will. But that's a person that is at high risk for developing diabetes type 2 later on in her life. So the other conditions that result in diabetes that should be mentioned here is cystic fibrosis, pancreatic cancer, post-transplant diabetes, PCOS, so polycystic ovarian syndrome. That person should be screened for diabetes. And other classifications that I won't go into too much here on this talk, that would be a great later talk because it's interesting, is LADA, or latent onset autoimmune disease in adults, or MODY, M-O-D-Y, maturity onset diabetes of the young. And there's different, that's a genetic diabetes. There's 11 subtypes. So that's interesting to me. And I would love to present a talk just on that. So to review in my next slide, just what are the types of diabetes? So type 2, the body cannot use insulin properly. So it's a concern of insulin resistance, and I'll talk about why that is. So glucose cannot enter the cells. It's more common in adults. It's becoming more common in our teenagers and young adults. Type 1 diabetes, the pancreas cannot make insulin. So it's an insulin deficiency, and that can develop at any age. I have one young man, he's now in his late 20s, and he was diagnosed at the age of 4. So my next slide is courtesy of Park Nicolette, and it's a simple slide. I'm sorry you can't see it, but I'll describe it to you. But since I have Park Nicolette up on my slide case here, I wanted to say that that's how I got my initial training. I spent a week at Park Nicolette at the International Diabetes Center there in Minneapolis, Minnesota. It's like this amazing Mecca place. And so for a week, I arrived there. I was given a glucometer. I was given a vial of normal saline and some insulin syringes and a journal. And each morning I checked my sugar fasting. I checked it before each meal. I learned to calculate how many carbohydrates I was eating, and give myself an injection of saline just as if it was insulin. And so for that whole week, along with that practice and then lectures every day, it was a wonderful learning experience. And so I'll always appreciate Park Nicolette. I have been lucky enough to go back there 3 times. It's an amazing place for learning. So to review in simple terms, what causes diabetes? The muscle and fat become insulin resistant, mostly due to inactivity. The pancreas makes no insulin, that would be type 1, or the insulin is less than what is necessary. So there becomes an insulin deficiency. And the liver is not participating in that delicate dance of glucose management. The liver makes too much glucose. And so the end result, and all these little parts, all point to a high glucose level. So risk factors for diabetes, diabetes type 1, a risk factor would be a relative with type 1, although I know many who have no known family history, a personal history of autoimmune disease like thyroiditis or rheumatoid arthritis. So an autoimmune disease is a condition that attacks the body. And in this case of diabetes, it's attacking the islet cells, the beta cells of our pancreas. So risk factors for type 2 diabetes would be strong family history, advanced age for most, so age over 45, a personal history of gestational diabetes, being overweight, being physically inactive, and a personal history of prediabetes. So common symptoms that might bring someone to ask for a screening would be fatigue or feeling tired, increase in thirst, increase in urination, unexplained weight loss. For individuals with type 1, usually it has a rapid onset of sudden rise in your blood sugar, and those individuals are really sick. They tend to go to the emergency room with vomiting, abdominal cramping, and are started on insulin right away. So my next slide is another look at that beautiful poster. I'm sorry you can't see it, but just to appreciate the magnificence of that pancreas. So I wanted to review again, and making it simple, another Park Nicolette cartoon slide is how does glucose and insulin normally work together? So I hope I'm not being redundant, but I want you to understand how that all works. So we're eating something, our blood sugar goes up, that triggers the pancreas to release insulin. So glucose and insulin enter the bloodstream. Then insulin attaches to that cell and actually sort of like opens the cell, if you will. It's the key to open that up to allow glucose into the cell, because we cannot use that glucose in the bloodstream. It's irritating to the endothelial lining of the bloodstream. In fact, it causes damage. So it needs to be in the cell. That's how we can utilize that glucose that we're eating. I'm going to put my phone right there. So it's diagnosed with a simple blood test. This is not hard to diagnose. So a simple blood test, basic metabolic panel. You could go to health screening or comprehensive metabolic panel. It does not need to be fasting to be diagnosed. But so a normal fasting glucose, since that's what I have written on my slide, is 70 to 100. But if you did a random glucose, it would be anything over 200 milligrams of glucose per deciliter of your blood. For prediabetes, it is a fasting glucose. So prediabetes is suspected. I usually go back and do a second test and add an A1C, but a fasting glucose of 100 to 125 is someone who should have additional testing and education on lifestyle modifications. 100 to 125 is the diagnosis for prediabetes. That would be fasting. If it was a random blood test for prediabetes, it would be 140 to 199 milligrams of glucose per deciliter of blood. My next slide is a simple slide from Park Nicola that shows the correlation between the hemoglobin A1C and what your average blood sugar would be. And so if your A1C was 5, your average blood sugar would be about 97. If you're on the other end of the spectrum, if your A1C was 14, your average blood sugar would be about 355. So how is that measured? I remember, I'm old enough to remember when we first started using a hemoglobin A1C, and I attended a grand rounds with Dr. Glasseroff, Alan Glasseroff, and he was describing on the blackboard how this was all measured, and my mind was blown. I was like, wow, that's incredible. So they're looking at the hemoglobin molecule, our red blood cell, and how many of those are totally saturated with glucose, right? And so it's a retrospective look of the past 90 days, because we regenerate our red cells every 3 months or every 90 days. So it's a look back over the average A1C. Now, what we know now about the A1C is, while it's still a helpful lab and it's good information, just like a glucometer when people are testing their blood for glucose, that's helpful information. And certainly your regular annual screening for blood sugar is helpful information. But as a diabetes care and education specialist and a primary care provider, I'm looking at time and range. And so that's the one thing, well, not the one thing, but that's, to me, the most important thing that the continuous glucose monitor has taught us. There's so many data points. It's been out for a long time. A CGM measures your blood sugar every 5 minutes, right? And so that's a hard thing to do. Your fingers would get pretty sore if you used your glucometer that often. Besides, Medicare's not going to pay for it. So the CGM shows us time and range. And so if a person, well, let me back up. With the A1C, it's showing you an average. So a person, and I've seen this before, might have an A1C of 6, but their blood sugars might rise to 300 or 400 after a meal and crash down to 50 at bedtime. So while it's information, it's not the whole story. And so that would be another lecture or a conversation that we could have about time and range. But it's very important. The range that would be optimal, if a person can maintain between 70 and about 180 throughout the day, at least 70% of the time, you would be, really able to manage your diabetes well, with minimal damage to all those blood vessels throughout our entire body. So all the complications would be limited or put off for as long as possible. So the treatment for type 1 diabetes includes insulin using vial and syringes. These days, there's wonderful insulin pens that are great. Smart pens are even out that'll tell you what your blood sugar is and give you suggestions on how much insulin to take. And then, of course, insulin pumps. But diet and exercise are essential for treatment of type 1 diabetes. A person with T1D, type 1 diabetes would need to monitor their blood sugar throughout the day using a glucometer or a CGM, continuous glucose monitor. And then they also need to pay attention to their eyes, their cholesterol, their blood pressure, and renal function. So usually we start those kind of screenings about 5 years after the initial diagnosis. And then support. So support is super important. Diatribe is one of my favorites, and Take Care of Your Diabetes, or TCOYD, from San Diego. Dr. Edelman is awesome. He uses a lot of humor in his vignettes and virtual conferences that he does. So you can Google TCOYD or Diatribe. I receive emails from Diatribe once or twice a month. This is a wonderful book from Adam Brown. If you haven't read it and you have or know somebody who has type 1 diabetes, it's free online. I got this at one of the conferences I went to. You can buy it for $20 and put a donation in. It's fabulous. It's called Bright Spots and Landmines, with a subtitle of a diabetes guide I wish someone had handed me. So it's a great book with recipes, with support, just sharing knowledge, because knowledge is power. So a little bit of history on insulin, because it's a lifesaver and it's interesting. Prior to 1921, there was no effective treatment for someone who had T1D, so type 1 diabetes. Dr. Frederick Banting and his medical student, Charles Best, actually did dog models and unfortunately removed pancreases and tried to extract insulin from that dog pancreas. So we honor our dogs for helping people live. Later, it was taken and extracted from cattle by Doctors McLeod and his associate Collip. In 1922, the first young man he was dying, he was 14, his name was Leonard Thompson. He became the first person to receive an insulin injection, which was life-saving. So Banting and McLeod, the two doctors that worked on both the cattle and the dog pancreas and developing insulin, received a Nobel Prize in 1923. And then Eli Lilly, which is a pharmaceutical company still going, they started large-scale production of insulin from cattle. And then Novo Nordisk started using varieties of longer-acting insulin from cattle and pig. I remember all this, of course, not in 1936, but I certainly remember in 78 and 82 when the synthetic human insulins were available. They were a lot more stable and just, a huge improvement. So I had a couple of slides showing a man sort of sloshing around in all these pancreases from, I'm assuming, cattle. He only has gloves on. It's an Eli Lilly slide. I'm sorry you can't see it. I'd love to show you sometime, because it is pretty funny. He doesn't have a hairnet. There's no mask. He's just sloshing in all these pancreases here. So today, my next slide is asking, how many types of insulins are there now? We have 22 approximately. I mean, there's new all the time. Whenever I go to my refrigerator at work, I would say, what is that? There's new things coming all the time. There's combinations, biphasic insulins, rapid acting, and extra long acting. So, and everything in between. And so the latest thing too is an inhaled insulin. It's been out since about 2006 when it was taken off the market. And but Frieza and Gypreza are the inhaled insulins that are ultra rapid acting. Type 2 diabetes, remember it's insulin resistance with a resulting elevated blood sugar. We did talk about the risk factors, so I'm not going to repeat that. The treatment plan for type 2 diabetes, and this is a Park Nicolette slide that I have up, is food and activity. It's all the way through. So food as medicine and activity is just absolutely, necessary. And we'll talk about that more as we talk about, pre-diabetes included. But there's lots and lots of medication options. So many options for medication to treat type 2 diabetes. Metformin is usually the first one that someone might be started on. I would recommend the extended release metformin. It's easier to tolerate, and go slow with that one because most people have problems with nausea and diarrhea. So taking it slow, using the extended release. What metformin does is it helps to sensitize the cells in the fat and muscle. It decreases the absorption of glucose through the gut, so you're actually getting rid of it through your stool, and it decreases the liver production of glucose. So it's targeting several different problems or concerns with type 2 diabetes. My next slide is the IDC's log algorithm for treatment, and it's amazingly complex. Most primary care providers, have this in their office. The number one part of treatment for type 2, again, is self-management. So in other words, visiting with a diabetes educator, visiting with a registered dietitian to learn about medical nutrition therapy, activity, lifestyle modifications, and emotional health. Exercise, again, is so important. That's the mainstay, and throughout the treatment algorithms, no matter what you're using, whether it's insulin or whether it's the new popular ones like the Flozins, the SGLT2s like Jardiance and Farxiga, actually the Flozins, if you will, are the amazing ones. They win the popularity prize. Because they also help your heart, protect it against congestive heart failure, and they help the kidney function out too. So they're blocking your reabsorption of glucose so that you're actually peeing it out. So if you had a urine test and somebody sees urine or glucose in your urine, it's because of that SGLT2 if you're taking an SGLT2. I'm so old that, how old are you? I'm so old that that when I was a new nurse, and LVN is where I started in 1976. Wow. So last century, we would test the urine, have a little test kit, test the urine with the dipstick chemistry, and see how many milligrams of glucose are in someone's urine. So if somebody had 1,000 milligrams of urine in their of glucose in their urine, then we would somehow guess, well, we'll give them how much regular insulin. So as you can see, we've come a long way with a lot more science and clarity in our diagnostic skills and monitoring. Amazing. Anyway, so the next slide is showing about physical activity that lowers your blood sugar level. I've had people in my support group who tested this out, so they would measure their blood sugar before they ate, they would have their dinner and go for a walk and watch their blood sugar go down, right? So physical activity is essential for diabetes type 2 and really all the diabetes, because it helps to manage your diabetes, your blood sugar. And that's what we're trying to manage here. So I wanted to switch gears from diabetes to pre-diabetes. So remembering that pre-diabetes is what it says. when my father was diagnosed with diabetes, he told me, well, you know, I've been a borderline diabetes or diabetic, he would call it. I've had pre or borderline diabetes for years, you know, but when it's on the border, it's over there somewhere. And so I find that pre-diabetes is a more accurate description, and perhaps helps a person realize that they need to make some lifestyle changes. So what are the risk factors for pre-diabetes? Age 45 or older, body mass index greater than 25, family history of type 2 diabetes, history of gestational diabetes, inactive lifestyle, history of high blood pressure, abnormal lipids, which includes low HDL, high triglycerides, and high LDL. So does that sound familiar? Yes, it's the same risk factors for type 2 diabetes. The treatment for pre-diabetes is education. Education is king. Education is really empowering. So education on the importance of a healthy diet and encouragement to get active. Activity can be individualized because certainly as we get older, you know, we're not able to run as much, or, you know, the knees hurt, the back hurts. And so, but individualize it. Think about what you can do. You can dance, perhaps, you can hula hoop, you can jump rope, which I was trying to do this morning. You know, put some strengthening exercises in there, do a little yoga and Tai Chi. Find something that you like to do. The American Diabetes Association recommends 150 minutes of activity a week. So, you know, that comes out to about 20 minutes a day, which is not that much to help your blood sugar out, help your body out. So what does physical activity do besides lower your blood sugar? It promotes weight loss. It does lower your glucose level. It improves blood pressure and cholesterol levels. It increases strength, endurance, and energy. It creates a feeling of health and well-being. It reduces stress, improving mood and emotional health. And it probably helps your sex life too. I mean, physical activity helps everything. And we live in Humboldt. So this, I'm sorry you can't see this slide, but this is a slide of a huge, beautiful redwood tree up at Prairie Creek. My husband is hiking around the tree. But in Humboldt, we have so many places to go. We have such beauty. We're surrounded by beauty, even along our streets, looking at the houses and people's gardens. So get out and go for a walk. All of us need it, especially as we get older. It's one of the few modifiable risk factors that we have left. So to review the lab values to diagnose prediabetes, it's a fasting blood sugar of 100 to 125, or a random blood glucose of 140 to 199. And you can Google all of that. So what is eating for better health? We want to choose to eat foods that are rich in vitamins, minerals, fiber, and other nutrients that promote health. So eating when we're hungry and stopping when we're satisfied, because we need to learn to recognize those hunger cues and when we're satiated. Being aware of portion sizes, and that's something that I love to help people with. Choosing appropriate amounts of food. So this is, I'm going to put my phone down here and hope it doesn't fall, but this is something that I use in my diabetes education classes. So it's planning healthy meals. So we want to, you know, eat lots of non-starchy vegetables, whole grains, lean meats and fishes, and have your plate have color. Make your plate have color. So if you're going to have pasta, make it more of a side dish instead of a main dish, and make sure you've got lots of green and orange and color there, you know, and a little space for your protein too. Plug for soy. You know, the Arcata Tofu Shop just makes an incredible product that's really delicious. You know, it is something that you develop a palate for. So carbohydrates will raise your blood sugar. They are one of the 3 main macronutrients. So carbohydrates, fats, and proteins. So we want to choose carbohydrates that are whole grain, that are fruit, real fruit, because of the fiber. You choose legumes like beans and peas and lentils and soy, and the sugar-free or plain dairy. You want to really limit white bread and desserts and pastries, even though it's the holiday season. That would be a limitation, not a total exclusion, you know, but you can't party hardy every day. We know that. We should know that anyway. So you also want to avoid sugar sweetened soda. Forget about juice. Eat the orange. Don't drink orange juice, even if it's organic. Energy and sports drinks are probably really causing our children to gain weight. And so I don't think it's necessary unless you're a super athlete. You know, water is fine. You can flavor your water with you know, orange flavoring or something. Anyway, you know, avoid those sugar sweetened coffee drinks. You know, sometimes I don't know how many times I've talked to someone about what they're eating. We're just taking a little history, and folks will just be very distressed at the diagnosis of diabetes. You know, I don't know why I have this, or I don't know why I can't lose weight. I'm not eating anything, you know? And so that's when I say, well, what are you drinking then? You know, it could be the mocha, you know, that's putting those extra calories there. So I have another slide from Park Nicolette about choosing, you know, vegetables, fresh or frozen, can or fine too, just rinse and drain, lean proteins, whole grains, and starchy vegetables. If you're going to choose a starchy veggie, go more with sweet potato because of the fiber, quinoa, whole oats, not instant oatmeal, brown rice. There is some really great different pasta choices now. So really, it's a better time to have diabetes. There's improved medicine, there's more information, and most of our food comes with you know, readings on how many carbohydrates per serving, and you can learn you know, how many carbohydrates is in an apple. So a normal apple, just to digress a little bit, is 15 grams of carbohydrates. That's a whole nother lecture that we could talk about, is how do you read a label? You know, what do I eat is what a lot of people want to know. So I'm just sort of giving you an overview of everything because it's complicated. There's a lot of stuff to cover. But I wanted to tell you that the CDC has a diabetes prevention program. It's just go online, cdc.gov/diabetes/prevention. So cdc.gov/diabetes/prevention, and read what they have to say. And the main focus of that is lifestyle modification. And that's easier said than done. We'll talk about that. Support is really needed. So my next slide is a picture of SpongeBob, and he says, what? There's an emotional side? There is a huge emotional side to diabetes. There's diabetes burnout. It's just, you know, it's difficult. It's hard. It's something hard to think about all the time. But we need to think about emotional health. Many people, in fact, eating to soothe themselves, right? I don't know about you, but I know a lot of, I wouldn't say me, well, yes, okay, me. So, you know, put on our 5 or 10 pounds of COVID stress of foods, you know, so we put those pounds on, we've got to work on getting those off. So we want to, you know, try not to eat to soothe ourselves emotionally. So this slide, thank you, Park Nicolette, says pay attention to your feelings. address your feelings about diabetes. And that's another thing that we do in the diabetes support group, is share our feelings with people you trust, maybe people who are going through it too. Continue to learn about diabetes. And I am someone who's been studying diabetes for, a decade and a half, and I'm still learning things. There's new things out there all the time. So continue to learn. Do activities that use your creativity. That's a good way to help with emotional health. Be physically active. And, and then the next part of that one that we can talk about is maybe you can have some ideas of your own to help with emotional stress. So, how to feel less stressful. You should be physically active. I think taking a walk with my dog has helped me a lot. Work in your garden. We want to learn to breathe deeply. That helps. Even just taking a moment to take some deep breaths. Make sure you're getting some good sleep. Sleep is important so that we can feel less stressed. Learning to laugh or find some kind of what's the word I'm looking for? It's just an amazing coincidence, serendipity. What the heck kind of moment. Sometimes that's funny. Sometimes it makes you cry. Take time for yourself and relax. I have a couple of handouts here on being mindful, eating mindfully. Take a moment to do some quiet meditation, and it doesn't take a lot of time. It really doesn't take a lot of time. So my next slide is what I use on every time that I'm doing a support group or diabetes education. And it's the AADE 7. So it's the American Association of Diabetes Educators 7 self-care behaviors. Because while I am a diabetes educator, a person who lives with diabetes needs to be the main person to know. They need to know more than anybody else about it because they're living it. But what I try to work with people is living or healthy eating. And we've talked about a little bit that today. Being active. We've certainly talked about that today. Monitoring. Taking your medication. So talking about questions about medications is super important. And I love to spend time doing that. Problem solving, which I think is probably the hardest thing. Healthy coping. So that gets back to emotional aspect of diabetes care. And all of that is to reduce risk. So that's the last one, is reducing risks. So the most common challenges that people who are newly diagnosed with diabetes, there are several. And so one of them is feeling unable to live well with diabetes. It's just this huge kind of blow, and so it's complicated. And so we take it bit by bit. But an individual might feel lacking in the confidence to manage diabetes every day. But you can learn that, especially with help and support. Many people lack the support from family and friends, or there's the diabetes police, checking everything they're eating. Are you sure you want to eat that cookie? So, and then, being unable to afford diabetes supplies and medications. Everybody's heard about how expensive insulin is, and it's a crying shame in the United States. The supplies are expensive, and trying to get it through our insurance companies is a nightmare for myself as a primary care provider, and also for the patient who really needs that continuous glucose monitor, for example, or new test strips. Another challenge on this slide is being unable to regularly get food that is better for your health. So even in Humboldt County, in our largest cities, those that live in the center part of the city might only have a small little store that's near them. They may not have a functioning car or the ability to get to the grocery store to carry home those heavy bags of fruits and vegetables and lean meats and things that they need. So they're buying what's available. So food deserts throughout the United States is a crying shame. And I think talking about diabetes and pre-diabetes, you also have to think about our food source and why is it that healthy foods, fruits and vegetables, lean meats, and all the things on the perimeter of our grocery stores, why are they more expensive than the Pop-Tarts and the things in the frozen section of our grocery stores? So being unable to regularly get food that is better for your health, that's a crying shame in the United States of America. And while I don't have an answer for it, that is something that needs to be changed. I don't know. Do you think it would help to write our Congress people? I don't know. But anyway, I have this final picture is a picture of our beautiful Humboldt Bay. This was just a couple of weeks ago. I was walking down there and the water was calm. There was someone in his kayak and it was a moment of peace and tranquility and it was beautiful. And it just makes me be thankful that I live in Humboldt. Just driving between Arcata and Eureka is a treat because it's beautiful. So we live in a beautiful area. We need to get outside, do your best. The final slide is, and how am I doing on time? Not bad. So the final slide is, I'll get to diabetes neuropathy. You bet. You want to quit smoking. That's a really huge risk factor. Why? Because people who smoke, it's damaging to the blood vessels, right? And so, the biggest part of smoking is heart disease. The biggest side effect and most common side effect of type 2 diabetes is heart disease. You want to see your provider regularly, more than once a year. I would say every couple of years, and take your shoes off. So you want to visit an eye doctor. If you have type 2, you should do that as soon as you have a diagnosis. Have them do a dilated eye exam, looking at the blood vessels in the back of your eye. And don't forget the dentist. Actually, what I would really say is don't forget to dental floss and brush your teeth. So it should be a couple of times a day that you're doing that, because oral health and periodontal disease puts bacteria and inflammation, which is also damaging to our heart. So our teeth are very important. And it also helps you to eat fresh fruits and vegetables when your teeth are in good condition. Someone asked about peripheral neuropathy. This slide, which I'd hoped to keep up until we did our Q&A, is about looking at your feet. So peripheral neuropathy relates to the fact that chronic high glucose levels are irritating to the endothelial lining of our blood vessels, right? So those blood vessels also innervate our nerves, right? And so peripheral neuropathy, when it pertains to diabetes, and some people have peripheral neuropathy that maybe it's from chemotherapy, maybe it's from unknown causes. I've had a couple of folks like that, but most folks with neuropathy are have diabetes. And so peripheral neuropathy is related to the blood vessels that innervate our nerves. And so the nerves become damaged. They're not as sensitive. Our fingers are very sensitive and our feet are very sensitive. So we need to visually look at your feet to make sure you don't have a rock in your shoe or a thorn in your sock. You're not walking around, you're not putting your foot into a super hot bathtub. So I would encourage you, when you go to see your provider, to take your shoes off, because that's a time-consuming thing. Everybody's rushed. So take your shoes off. It gives your provider a cue to look at your feet, but also then you're all ready to have your foot do a professional, monofilament test where they're actually testing the sensitivity in the toes and the foot. And lastly, listen to your body. Work on the emotional component and have some routine follow-up. So someone asked about peripheral neuropathy, and I hope I answered that. So then someone is asking about, Carolyn is asking about non-caloric sweeteners. Well, I think I think they're certainly safe. Splenda has been looked at over and over again, but I think the problem with our artificial sweeteners is that they increase, they don't help us to readjust to what a natural sweetness is. You know, pineapple is sweet, very, very sweet, but when we use a sweetener in our tea or coffee or whatever, it can be up to 13 times or 1,300 times in the case of stevia and Splenda, 1,300 times more sweet than regular sugar. So while sweeteners help you to make things palatable, you can certainly cook with some of them. I would encourage you to try to get used to not using sweeteners on your oatmeal or in your coffee, but it's an adjustment period. I didn't see all the other questions.
Let me help you with that.
Okay.
There is a question about what is the difference between whole oatmeal and instant oatmeal? Why is whole better?
Got it. Great. Okay. That's a great question, and I appreciate that. I appreciate all your questions. And they're all great, and I appreciate that. So the difference between instant oatmeal or the little packs that you get is that most of that fiber has been removed. So they're instant oatmeal. So oatmeal, and a lot of people say, well, I bought myself some oatmeal, you know, thinking that'll cure their diabetes. There is no, it's not a panacea. The main benefit to oatmeal is fiber. So fiber is going to help your body digest. And by digesting that fiber, you're actually using up some of that glucose. And it also lowers your cholesterol by pulling it out of the intestinal system, and you're actually getting rid of it that way. So the difference between instant oatmeal and certainly those packets that are like candy, really, you know, if you looked at how many carbohydrates is in that and how much, you know, how fast your sugar rises when you're eating the instant oatmeal, the difference between one and the other is one, the old-fashioned oats, the rolled oats, still has a lot of fiber in it. So you get that benefit of a fiber-rich food. The other has been processed more, and so the fiber has been removed for the convenience of rapid, you know, preparation, food preparation.
Great. There's a couple of comments in here. One is that while I was an ice cream kick, she's a type 1 diabetic, and her family was horrified that she would eat ice cream every day. And this person says when they were at the Mayo Clinic, they asked about it, and the Mayo Clinic people said, eat what you want. It's just make sure you cover it with insulin. Is that, could you address that? Is it okay to eat what you want?
Right. Well, you know, I guess I would put a caveat with that is, you know, within limits, right? I mean, in a perfect world, you know, and perhaps when we're really young, you know, you can eat as much as you want, drink as much as you want, and there's no, you know, side effects to that, you know. So in someone who has type 1 diabetes, that's probably true. We used to say that a lot, you know, just go ahead and give yourself some insulin. But insulin is not completely harmless. You know, it's a hormone. It will increase your hunger craze. It can put on some weight that, of course, you don't want as you age with type 1 diabetes. And so it's all within, it's all about portion size. So ice cream is not a sinful thing, you know, but a portion or a, you know, serving size of ice cream is about like a hard ball, you know, or a tennis ball. So, you know, 15 grams of a carbohydrate source, whether it's an ice cream, which has a lot of fat in it. So you want to watch your cholesterol too, you know, but it's still got 15 grams of carbohydrates. So if a person was to have a half a gallon of ice cream, that's way over. and that would not be healthy. But certainly, you know, if a person really likes ice cream and it just makes their day, then maybe they can avoid eating cookies with it and don't put any sugar in your hot chocolate or your, you know, tea. This book, Bright Spots and Landmines, that Adam Brown writes about, he addresses that too, that when he was first diagnosed, you know, they just told him, just eat whatever you want as long as you match it with some insulin. And so what he found, that he was chasing his tail, you know, and so he would eat something, he would take an insulin on top of that, and then maybe he would crash. And so then he would eat something. And so he was doing this yo-yo, and that just makes you feel horrible. So you might feel better if you didn't consume a whole lot of carbohydrates at one time, but spread it out throughout the day. So it all comes to quality of life there. So that's where it depends, you know. So serving size of an ice cream is not bad. And then looking at the whole of the day, hopefully you're not eating ice cream throughout the whole day, you know. So the rest of the day, you might be having some whole grains and some fruits and vegetables, and maybe you just took a nice long walk, or you went for a run and played some tennis or pickleball or something. And there you go. So it all comes out. So it just depends, right? So
Got it. Thanks. What are the names of the once a week injections for diabetes?
got it. So that's the Trulicity or Ozempic, you know, oh, it's magic. So Ozempic and Trulicity so I'm trying to think of the third one, and I should know it, but it's not in my brain right now. So they are they're newer, the GLP-1s. So they're looking at the gut, at the incretin system. So remember, when we eat something, goes to our, well, actually amylase starts digesting it, but it also goes to our stomach that churns it. It triggers that release of insulin. So it starts actually in our gut, and Trulicity and Ozempic, and I'm going to kick myself for not remembering the third one, the once a week GLP-1 agonist receptors, they're actually improving that a little bit. So that's boosting that incretin system. That's increasing a little bit of insulin to help digest it fast. It also works in the brain level. Is that what you're asking me? Is how does it work?
They just asked what were the names? That's all the
Got it.
question said.
Yeah. Okay. Yeah. See, I could go on forever. You know, your eyes glass over, and I'm still talking. But anyway, they're great. I think they're great. In fact, in the current day scheme of things, I tend to do lifestyle modification and education about how to use a glucometer, give them support, give a person support. This is type 2. We don't really use that for someone who has type 1 yet. It's be off label, if you will. But I work with a sensitizer like metformin. And then the next on that algorithm would be the incretins, you know, like the GLP-1As. So that would be Onglyza or Trulicity. They're great. And the reason why they're great is because they're very effective. And they seem to, you know, you're not you can lose a little bit of weight. So remember that insulin sensitivity happens with even 5% of weight loss. You don't have to go to any target weight that you might think is whatever your perfect weight is. You know, it doesn't have to be that way. So GLP-1s are fabulous. Certainly the once a week is easy. But it also comes like Victoza is a once a day thing, and some insurances will pay for Victoza, but they won't pay for Trulicity, even though it's the same medication. Trulicity is the longer acting, so it's just needed once a week. So they're great medicines.
So it looks like Bydureon.
Oh, Bydureon. Yeah, Bydureon. There you go.
Yeah.
It's a little more clumsy. You have to sort of mix it. I think nowadays it may be pre-mixed, so that's an improvement. But it's a once used syringe. So in other words, you're using it Bydureon and Trulicity, and you toss it out. It's a plug for Ozempic, but you know, with Ozempic you actually have 6 doses. depending on your dose level, but it's a reusable pen. You change the needle out. And so that's a little bit easier on our environment because we're not making as much medical waste. But, quite frankly, it just depends on what your insurance is willing to pay for. So they're all great. Yeah, by Durian. Thank you to whoever put that.
That's Carlisle.
There.
Thanks, Carlisle.
Right.
Also, Rita put in the comments that Novo Nordisk has a program to give insulin for free to those who can't afford a program called My 99. 3 vials of insulin for $99 or 10 pens for $99. So for those of you who aren't reading the chat,
Kim, I'm going to correct you. It's for people who can't afford it, it's free. For middle class people who don't want to spend, $100 or $200 or $300 on a vial. It's something, the program is My 99. And that's 3 vials of insulin for $99 or 10 insulin pens for $99, up to 12 orders a year. And then at the beginning of the year, you just have to re-up on the program. Kathleen, I sent you information on this a year ago, but I never knew if it got to you. Maybe it didn't.
Oh, I didn't get that. Yeah. I'll look into that. I appreciate that. Yeah, they're often in my office, and I have not worked since May. I'm going to be starting back again in December. COVID sort of, put a kink into things as we all experienced. But I was often given, cards to help with payment on these things. And oftentimes that's not an easy thing for a person to use. They're little, but maybe this is better and I'll check into that. I appreciate that.
So a couple more questions. There was one comment about when you were talking about the oats, and just wanted a confirmation. What about still oats versus just regular rolled oats? Is there a difference in the way that they're processed?
Right. So steel oats they're just cut differently. And there are lots of fiber there. So I'd say they'd be great. I wouldn't get the quick steel oats, but a good Scottish steel oat is delicious. And I love it too. Takes about 45 minutes, I think, to cook. But yeah, so fiber is the key. So that's a great question. I appreciate that.
Thank you. And then could you speak to the idea that Alzheimer's could be renamed type 3 diabetes?
Oh, well, I don't know about that, but but dementia, because going back just to remind everybody that what is the main, why do we have these complications with amputations and heart attack and, blindness and kidney failure and dementia? It's because of the blood vessels that innervate our entire body. So it's not just, in one spot. So it's throughout the body. So chronic. So that doesn't mean just because you have a diagnosis of diabetes type 1 or type 2 or pre-diabetes that this is all going to happen to you. You have some modifiable, risk factors that you can address and try to motivate yourself to fix. But chronic hyperglycemia, chronic high blood sugar does affect your brain. You bet. So I don't know about Alzheimer's. That's a little different subject, but dementia, which is different from Alzheimer's, vascular dementia, definitely, yeah, you're at risk for that. And so that's why, the brain, the nervous system, the kidneys, the feet, because of the nervous system, the skin, so many things. So get some support. I hope that we can provide support, that I can provide support. If people are interested, I would love to do this, quarterly or whatever is helpful to people. Is there any more questions?
There's one more question that I see here. And it's just if you could make some comments about nuts and seeds as a snack.
Yeah, right. So the nuts is a fat. And so that won't raise up your blood sugar at all. And so I think that's a great snack. The problem is that there's a lot of calories there. So unfortunately, there is no free lunch. And so we can't just make a whole meal out of the fats, but those are healthy foods to eat. I would definitely say, because of fiber in the nuts. that's a great thing. You just have to, you know, it's like a serving size, if you look on the box, is very small. I'm saying like less than ping pong ball size. So, right. So, but you know, 10 almonds, which I like to have every morning, you know, along with the breakfast, you know, so 10 almonds is delicious and satisfying, and but not the whole bag, right? So that's how we get stuck, I think. And maybe, you know, and that's a whole nother lecture too, is like, how did we get into this mess, right? You know, the portion sizes are huge. So if you ever purchased one of those little you know, peanuts in a bag and you're eating it, and then you look at the label at the serving size and it says it's actually made for 4 people, right? That's how we got into this mess. You know, we got fooled and, you know, sort of satiated with, you know, too much TV, you know, food that's delivered to our house and things like that. So, you know, I have one thing that I kind of thought if we had time, I really thought might be fun, and that is a pre-diabetes risk test that would be easy for me to read to you. And but I'll answer any other questions. That'll only just take a, you know, a little short time. And then we could also talk about what are your goals for glycemic, you know, control. You know, what's your goal, A1C, and things like that. But anyway, this is really great. I really appreciate your time. Thank you very much for letting me talk. I'm sorry about not being able to have the PowerPoint. You know, I can show it to you some other time. But anyway, thank you for your time. Yeah, so I'll address any questions you have. But if you wanted to do the pre-diabetes risk test, it's kind of shocking. I did it on myself and I was like, oh my gosh, you know.
I think so. Nancy, do you have a question?
Yes, Kate, is there any connection between UTIs and diabetes? 2 of my friends very, very ill with UTI, both diabetic. Is there any connection there?
Well, so the high sugar, so if a person has uncontrolled diabetes, in other words, if they have chronic high blood sugar, right, your body's trying to get rid of that sugar any way it can, right? And so it's going to try to pee it out, which is how the flozins, the SGLT2s work. They're blocking the reabsorption of glucose and you're peeing it out. Anyway, so urinary tract infections can be part of the diabetes complications just because, you know, we have that high blood sugar, so you're at more risk for infection. But quite frankly, urinary tract infections in females are just part of aging and part of lack of estrogen and the whole, you know, bacteria milieu of our genital urinary tract. Right. So less estrogen can cause reoccurrent and then multi-drug resistant urinary tract infections. And it's serious. So I treat that with a little bit of topical estrogen, like a Vagifem tablet or something like that. You know, so that's a serious thing, but it can be related, but it's not a given that someone who has diabetes will have reoccurrent bladder infections.
Thank you.
Somebody said something about estrogen cream. Yes, estradiol cream would help to prevent. So it's helping with the whole, you know, biosphere of, you know, the normal flora of our vaginal system and everything so close that a little bit of estrogen really helps that so that it maintains its healthy, you know, balance between bacteria, good bacteria and hazardous bacteria. So yeah, that was a good question. I mean, they're all great. Thank you for all your questions.
There are a couple other comments and questions. I know that people want to know how to get a hold of you, and they want to know, is your program paid by insurance? So we want to make sure that we give them all that kind of contact information. And then there's one other question about once somebody has neuropathy, how do you deal with it once it's established?
Right. So my diabetes support group has been free. It disbanded in March because of COVID. But I'm looking forward to returning to that. In fact, I'm hoping soon, maybe in December. My goal is, and of course, I'm kind of a real klutz with with computers. So is trying to get some help with a virtual, support group. But that was free. That was there was no charge. I never asked anybody for their insurance, and it was fabulous, and I loved it too. It was my best hour and a half of my whole week of work, and it was wonderful. So it was free. So my place of employment is Mad River Community Hospital. I'm at Humboldt Family Medical Care, and so I'm not sure if they're accepting new patients right now. So I apologize for that, but I stay tuned. What I hope to do would be to have that advertised again, or somehow I could put that information out to OLLI and let everybody know when that starts. And I hope really within this month that we can get that support group going. It's really important.
One of the options we have through OLLI is to have a routine group that meets regularly. We have several already. There is a minor fee to OLLI for setting it up. But we have several of them, and that's one possibility for you. You could do it through OLLI.
That would be awesome. I would love that. Yeah.
So
Kim
let's
can
talk
tell
about
you
that. What Jane is referring to is called a special interest group, and so we could do that as a type of support, kind of education about diabetes and symptoms, managing all of those things. So Kate, I'll reach out to you about that.
That'd be great.
I mean, technology is huge, the CGMs, what do we know about that? And how do they work? And how can I get one? Insulin pumps, all the new insulins, there's so much to talk about. It's great. I mean, I would love that. That would be awesome. So I'm going to put this phone down here, because if you have a moment, and this really doesn't take very long at all, this is from the CDC website. So it's pre-diabetes risk test. So the American the American Diabetes Association and the CDC put this out on their webpage. It's part of their National Diabetes Prevention Program. So it's really shocking. So the first question is, how old are you? Well, so I'll be honest, I'm 60, or I'm over 60 actually. So I get 3 points, because if you're 40 to 49, it's 1 point, 50 to 59, it's 2 points. So I've already got 3 points there. So that's 3 for me. Are you a man or a woman? Well, so if you're a male, you get 1 point. If you're a female, it's 0. So I'm off on that one. So if you're a woman, were you diagnosed with gestational diabetes? Yes for 1, 0 for no. So I'm a no on that one. The fourth question, and there's only 7 questions, so bear with me, because it's kind of fun and you should do this. Do you have a mother, a father, a sister, or brother with diabetes? Yes, you get 1 point. No, you get 0. Now for me, I have 1 of each. That's why I love diabetes. It's my genetic makeup, right? So I'm trying to work with my modifiable risk factors to prevent it. But I'm just glad I don't have, they don't give me 1 point for every family member. So it's only 1. So now I'm up to 4, right? So have you ever been diagnosed with high blood pressure? Well, I have. Another present from my parents, I'm sure. But if your answer to have you been diagnosed with high blood pressure, if your answer is 1 or yes, you get 1. If it's no, it's 0. So that means, what am I? So now I'm 4, so 3, 4, 5. So I'm already up to 5. Are you physically active? Oh yes, I love to walk. I'm active every day. So if it's yes, that you're physically active, you get a 0. That's good. If it's no, you have to add another point there. And then the 7th question is, what is your weight category? What is your body mass index? And then on this, it shows you, if it's, 1, for a lower number score, and 2 and 3 and so forth. So somebody asked how many points for 75. Well, well, as long as, 60 or older. So that includes you too. So you get 3 on that one. So I have 5. If you are scored 5 or higher, you are at increased risk for having pre-diabetes. That's why 1 in 3 of the United States people have pre-diabetes. I mean, it's shocking. So the only modifiable risk factors is what we eat, how much we weigh, and what we do with our body. So you've got to, get dancing, play some hula hoop, frisbee, whatever it takes, exercise from a chair. You can do yoga from a chair or from your bed, but we as Americans, and actually as human beings, we need to be physically active. Our body were made to be active. So I have a score of 5. I was totally blown away by that. So you can reduce your risk for type 2 diabetes and pre-diabetes by doing what you can. And as far as I can see on this one, you only have, unless you're a young person, you only have 2 modifiable risk factors. So you got to use what you've got. Take care of your bodies.
Kate, I really thank you for this wonderful presentation.
You're welcome.
I
Somebody
think you did a
had
great
asked
job.
about, somebody had asked about neuropathy and how to treat that.
Yes, I did.
Oh, good. I just thought I'd address that. I'm sorry. But I hope you took that pre-test because that was interesting. So neuropathy, so poor feelings or burning sensation in your fingers and your feet, treated, it's difficult. So I would start somebody with a Vicks vapor rub, eucalyptus salve that kind of helps to mask it. There are only 2 medications that are FDA approved for treatment of neuropathy. That would include Neurontin and pregabalin or Lyrica. So, they do help a little bit with that burning sensation. Acupuncture might help. TENS unit, transcutaneous electrical nerve stimulator to help with pain may help. And the risk of neuropathy, of course, is foot ulcers and foot pressure that you don't realize, after you've walked around town all day, that your shoes are a little bit too tight. So you lose that sensation. So prevention is probably the best thing there, as the treatment is not a perfect situation.
We've discovered 2 things that work. One is don't sit a lot. And if you're going to sit, put your feet up so you increase the circulation to your legs and feet. And secondly, keep your legs and feet warm.
Yeah.
Because again, that increases the circulation.
Yeah.
And it has worked with 2 rather close family members that I know have this problem.
Yeah.
And neuropathy works from your toes up, your feet up, your calves,
yes,
etc. And it's a burning sensation, which is really bad when it's bad. So
yes,
there are fixes, and we hadn't tried Vicks vapor rub, but that would have the same effect of heating the area.
It has that menthol that sort of helps with that pain. Yeah, so heating will have cause some vasodilation. The blood vessels dilate, and so you're going to get more oxygen down there, and it just feels nice and warm. Yeah, when we're cold, everything kind of clamps up, including those blood. Well, and that's what it is. It's the blood vessels that are clamping up because they're cold. So as the skin tightens. But yeah, that's a great tip. See, these are the kinds of things that we can talk about in the support group. Is what works for you. Oh, I'll try that, that kind of thing.
And you can get a mattress pad heater that heats the bed. So when you climb into bed, you don't lose the heat from your legs and your body into the mattress, warming up the mattress, and then you end up cold.
Right. Just be careful not to burn your skin. I think that would be the biggest thing with any kind of heating device. Would be, the risk of, because you can't feel, the sensation is not as strong. And so the risk there is burning the skin. And I've certainly seen that happen with heating pads. But yeah, keep them cozy and warm, especially in this holiday winter season.
Again, I want to thank you so much, and particularly for addressing my question, because it's an active issue.
Absolutely.
And thank everybody for coming.